capsule ligament, all with tension or stretch. I want you guys to start thinking about tension and stretch as under the same umbrella, but there's nuance and difference between the two. Stretch is something you're gonna hold. Just putting tension on something. Stretch is something you're gonna hold at end range. Tension, if I just hold something like this, I'm not at end range, am I? But if I had a weight in my hand, I'd be putting tension on my biceps and brachialis, yes? So you can put tension on tissue without getting an end range stretch. And that's important because that's how we heal tissue. We heal tissue by putting tension on it. If you load too much, you tear tissue. If you load too little, tissue atrophies. Okay. It literally is the difference between a couch potato and someone who's got to run 10 miles a day. You know, one's overloading, one's underloading. You got to find that balance in the middle. All of type 1 tissue is innervated. So when we use hot packs, when we use cold packs, when we use electric stim, even if you're rubbing the ultrasound head on the skin and you know it's penetrating deeper than that, but all of those modalities affect proprioception and nociception via the dorsal horn with skin receptors. So if you just take your fingers and rub your arm, you have peripheral nerves in your skin that is sending a signal in this dermatome. This is C5. Okay, that's going into the C5 nerve root, and that is interfacing with your spinal cord. And that signal can go to 3 places. Okay? So when I first learned this, I siloed it, and now we're integrating. Okay? We're pulling in different concepts in histology, neurophysiology, and then we'll get to manual therapy and treatment. Okay? So it goes to 3 places. The first place, it doesn't matter which, it kind of happens all simultaneously. So don't think of it as 1, 2, and 3. Just think of it as like an order. It's just 3. So it goes up to the brain, and then you have a sensation of, oh, I'm rubbing my arm. If you cut out the peripheral nerve, which in this case is axillary, if you cut the nerve root, if you cut the spinal cord, if you cut the nerve at any one of those places, it's going to not send a signal to the brain. And that will truly be, I don't feel anything. Not numbness, not tingling, just I don't feel anything. Okay? Just like these lights. If you cut the wire right up where the light is, the light would turn off, right? But if you found the wire over in the wall over here and cut it, the light would still turn off. Or if you cut the wire down at the light switch, the light would still turn off. It's one continuous signal. Peripheral nerve, nerve root, spinal cord. Okay? It all can affect that. So when you're trying to, the second place it goes is to the motor area. That explains why we get muscle guarding. That also explains how you can inhibit muscle tone with manual therapy. Or with a hot pack, or a cold pack, or a stim. Okay, or dry needle. Because your sensory nervous system sends a signal into the spinal cord, and it can block that motor area, which is sending a signal out to make the muscle tone increase. All right. The third area it goes to is the sympathetic nervous system, and that is, you don't notice that a lot, except for when you do things like heavy inputs, like thrust manipulation or dry needling. And this is where, like when you're dry needling someone, sometimes they get dizzy, sometimes they get nauseous, sometimes they break out in sweat. That is accessing the sympathetic nervous system. And it's not it's not a bad thing, but that's your warning sign to stop the needling, okay? And if you keep going, the patient's gonna pass out. I worked with CHTs for over 10 years, and I don't know what it is. I have never had a post-op knee patient pass out on me. I have seen people pass out looking at their hand after surgery. The first time it unwraps, just slump down in the chair and they're done. I don't know what the difference is between your hand and your knee. I don't know. I have a theory. your cervical spine is loaded with sympathetic nervous system. Your stellate ganglion, if you remember that from PT and OT school. So that's my theory, that you have more inputs. It also could be somewhat psychological. Your knee is important, but your hands are really important. So I don't have a good answer for you. All I know is it's an observation.
It's very good.
All right. So again, when you put your hands on someone, or the patient's in pain, and you put the hot pack, cold pack, stim, any of that, that's affecting the receptors at the skin level, and that's having an input into the spinal cord, and it can block the efferent signal out to the muscle, which is what we call muscle guarding. That's how your physical agents work, all of them. When we do deeper soft tissue, and that's type 1 collagen, right? Skin's type 1 collagen. When we do deeper soft tissue, myofascial release, whatever you want to call it, okay? In our curriculum, we call it cross fiber with motion, passive pump, active pump, okay? All of those techniques affect the next level down from the skin, which is the fascia. And is the fascia innervated with all 4 mechanoreceptors? It is. It is. So when we do myofascial techniques, or we do taping with stretch, we're affecting, of course it's on the skin, you can't get around that, okay, but your targeted tissue is the fascia. These will be test questions. These will be test questions, okay? Because as OTs, as PTs, we should understand what we're doing and how we're affecting the patient. Just like if you go to an oncologist, they should have a good understanding of how the chemo's working, or the radiation, or anything else, and answer those questions. Okay. All right. The next layer down for the fascia is the muscle tendon. Okay. And we're going to affect the muscle with the myofascial techniques as well. And then when we do our joint mobilization, we're targeting the joint capsule ligaments. Back to the muscle tendon. When you stretch a muscle, you do get inhibition. That's why it's not good to passively stretch before a match. I said match because it's FIFA time, right? But any kind of game, okay, there's great research on this. They looked at healthy 18-year-olds in groups of 40, okay, very specific, because that's how much a platoon is. So the Army did this. They had platoons stretch before PTO, their daily 5-mile run, whatever they do, and they had platoons not stretch. And the platoons that stretch had a much higher incidence of muscle pulls. Okay. And America's been behind the bell curve on this, and we've stopped. Like if I went to an NBA game or a soccer match or a football game, the warm-up styles of those pro teams are vastly different. And honestly, 25 years ago, when I just finished my residency and understood all of this, I went to a Heat game, and I would just cringe, because they'd be doing like ballistic stretching like at center court, and the whole team would be out around the circle at center court doing ballistic stretching, having someone force their leg over their head. It's just terrible. It's just terrible. And the reason for that is that when you stretch, you do get muscle inhibition, and that's because of the GTO in the tendon, the Golgi tendon organ in the tendon. That's the same stretch receptor that allows your reflexes to work. When you take a reflex hammer and you hit a tendon, you're getting a quick stretch to that, and it's causing the muscle to react. Okay, so you should be asking yourself, well, why don't we just stretch muscles when they're guarded? And that's because the GTOs are half the story. The other half of the story is the muscle spindle, and that doesn't get a lot of press. But when you passively stretch, you sensitize the muscle spindle. So when you passively stretch muscle guarding, it's contraindicated. I know that it might be like something that I know we've talked about here, but something that you might have done in the past, because it's common practice across the PT and OT world. But if you change 5 things after this year, that would be one of the 5 things I'd ask you. Just stop stretching muscle guarding, okay? And the reason for that is you get a temporary inhibition of muscle tone, but you sensitize the muscle spindle, so the tone gets worse. The other thing that happens when you stretch a muscle that's guarded is usually there's an underlying joint problem. And when you stretch, by definition, you have to go to end range. And many times you injure the underlying joint problem. I'm going to say all that again. Yes, you get temporary inhibition from GTO input, but you sensitize the muscle spindle, which causes more guarding long term. And then when you take any acute tissue to end range, you're potentially stressing the underlying problem. Let's say, oh, Thomas, it's not a joint problem, it's a muscle problem. I've literally seen therapists, athletic trainers and PTs stretch hamstring pulls. A hamstring strain is literally a tear in the hamstring. So if I had a little tear in my shirt, why would I pull it apart? It just doesn't make sense. So think of it that way. If you have a grade 1 sprain in your capsular ligament, that's literally micro trauma. That's micro tearing. Why would you stretch that? I don't know. Guess what I did when I graduated PT school? I stretched the shit out of people. And then I had an orthopedic residency that taught me histology. Okay? And how to apply PT modalities to that. Rehab modalities to that, OT and PT. Okay. So that's capsular ligament. So we're doing joint mobility for that. The mechanoreceptors are in that tissue. All 4 of them. Okay. Then we have type 2 collagen, which is cartilage. Now we don't test cartilage with stretch, we test it with compression. That's why many times your OA patients feel better in the pool because they're unloaded, or they have more pain when they're loading their tissue when they do squats and stairs, if it's a lower extremity. Or radiocarpal joint, if they put their wrist in extension, that usually hurts more. Okay? So, you'll have therapists say, oh, well, the cartilage is not innervated. Yeah, but the subchondral bone is. So, when the pain you're getting technically isn't coming from the cartilage, it's coming from the interface where the cartilage interfaces with the bone. So it's not bone, it's not cartilage, it's a mix between bone and cartilage, because you have this zone where there's both types of tissue. Okay, so that's actually what's causing the joint pain when you push on it. The scaphoid is famously avascular, so is the lunate. So if you have injuries to those bones and subsequent cartilage, they don't heal well because they don't have a good blood supply. But typically, what's happening when you have pain with joint pain, it's because of the subchondral bone. Okay, and then the SI joint's innervated. So anybody that says the SI joint dysfunction isn't real, I would just say 2 things. From an anatomical perspective, it's innervated with type 4 mechanoreceptors, so it absolutely can hurt. And then 2, I'm going to put you in touch with about every woman that's ever given birth, and they will definitely tell you that the pelvic floor or the SI joint can hurt. Which is, why you have epidurals and everything else when you're having a baby. After having 2 kids myself, I don't know how the human race got here. Because it's like, we've only had this medicine for about 60 years, 70 years. I don't know how women did it beforehand. No idea. Especially after you have 1. It'd be like, yeah, I'm not having any. I'm not going through that experience again. All right. So that's type 1 collagen, type 2 collagen. So basically, we're treating function with people, but we have to treat the tissue first because that's what's injured. And once you treat the tissue, then you can start treating function. Okay. All right. Cover mechanoreceptors, cover type 2 collagen, 2 types of collagen. All right. So we have 4 grades of. So I talked about the 5 main soft tissue techniques. There's a couple more in the book, but those are the 5 main ones. So we would do soft tissue first for guarding, and then we could do some joint mobilization. We have 4 grades of mobilization, and the 2 grades that I want you to focus on are grade 2s and 4s. Grade 1 is just the first 10 to 25% of the joint glide, and I say 10 to 25% because it depends on your reference. Okay. Grade 2s are 50%, everybody agrees on that. Grade 2s is just half the motion, and you usually hold grade 1s and you oscillate grade 2s. Then the Maitland group loves grade 3, which is mid-range to end range. I don't do a lot of grade 3s because basically you're basically throwing a punch from halfway towards the end wall, and you can injure somebody, especially if you got the diagnosis wrong. If they're really hypermobile and you're doing a grade 3, you can get into trouble pretty quick. So I just pretty much do grade 2s and 4s. So 4 is going to be an end range hold for tight tissue. So if you have a patient with limited range of motion and it's due to a joint capsule problem, you gotta stretch it. But you can stretch it with passive range of motion. So if you have a finger guides, you can stretch it like this, which is going to compress the joint, or you can keep the joint in neutral position towards end range, and then you can do a glide and not compress the joint. That's the difference between passive, okay? And you'll see therapists out there that are very lazy and they do a lot of passive range of motion to stretch joint problems. And that's not neutral, it's not correct. It's not correct because you're compressing the joint. You have to stretch the joint capsule without stretching the joint. And I wish we had a modality for that. Oh, we do, it's called joint mobilization, okay? I've literally seen therapists saying, you lose wrist extension a lot, and it's due to it. So remember, we can lose range of motion for a whole lot of things. Muscle guarding, fusion in the joint, tight joint capsule, we're talking about tight joint capsule. So if you can't extend your wrist, you have to do a volar glide at the proximal row, or one of the glides at the distal row, depending on which one we're talking about. And I've literally seen patients do this. Okay? That's just terrible. Okay? Why is it terrible? It's terrible because you're loading the joint, which is restricted and probably irritated, and you're trying to load the joint while you're gaining motion. So you're doing a double tap whammy. You're loading the joint and putting it at end range. So you're going to overstress the tissue, and the capsule's not going to be able to stretch that much anyway because the joint's already being compressed. So you can't hit the roll and glide in the joint that you need. All right. Is there a time to load the joint and try to gain mobility? Of course, when you're in the functional stage. I gave you a perfect example last time. If someone's lacking dorsiflexion and they don't have pain, a self-mobilization exercise is great. It's just have them do heel raises to neutral off the step. But if they had joint pain in their talocrural joint, I wouldn't do this exercise for the same reason I wouldn't have somebody with wrist pain do this to gain back their extension range of motion. If the joint doesn't want to be loaded, why would you overload it and then put it to end range and then stretch it on top of that? Okay? So think about that when you're gaining motion. If there's no joint pain or muscle guarding, you have a lot more freedom on what you can do. But if there's joint pain and muscle guarding, you have to treat the guarding first. Okay. All right, I mentioned a fusion. What about a fusion? What happens if you have a fusion? What should your first treatment be? Should it be soft tissue? No. Okay, soft tissue is for more superficial things and muscles. Okay? It should be grade 2 oscillations for 2 reasons. One for pain. What's the other reason?
Viscosity.
Viscosity, awesome. You're lowering the viscosity, so you're getting the fluid more watery. Okay, so how does fluid get out of an area? Does any fluid get out of an area when you ice it? No, it doesn't. Ice causes vasoconstriction. After a couple minutes, you get vasodilation. Okay, we all remember the vasoconstriction part. Anybody who's gone skiing or is from the north or just took a cold pack off a patient after 5-10 minutes knows that the skin is red. So you get vasodilation. And that's good, because otherwise you give somebody pretty much you give them a frostbite in 5 minutes if you didn't. Okay? So ice is good in the initial injury to keep swelling getting there. But once swelling's there, you only have 2 systems to get it out. What are they? Let's say. Yeah, to push it through what system? It's lymph. Lymph is independent of muscle action. What is dependent on muscle action? The vein, yeah. So 99.5% through the vein, 0.5% through the lymphatics. If you do muscle action, it really helps the the venous system.
Wait, what?
The veins are dependent on muscle action. Okay. And you know that because if you have I'm sure the OTs, you don't have to deal with this a lot, but we have surgeries in the lower extremity, you know, the possibility of a DVT is a lot higher. DVT is always possible after surgery, whether it's the hand or the lower extremity, but it's much higher after the lower extremity stuff, or spine. So you're gonna pump it out. Okay, you're gonna pump that fluid out. So are the veins in the joint? No. So all that fluid's in this water balloon with the joint capsule. So how do you get it through the water balloon? You have to make it more watery. How you do that is joint mobilization, oscillation, that's passive mobility to that joint fluid. You could also do passive range of motion, so you could move the whole arm, but that's typically more painful, so just doing a joint oscillation's nice. And then when it's more watery, and then you exercise the limb, the pressure of whatever exercise you're doing it multiple times, 30, 40, 50 reps, that's at 50% on one RM. That pressure of moving the joint pushes the fluid out of the joint capsule, and once it leaves the joint capsule, that's where the venous system is. It can get absorbed by the venous system and carve it out. So you don't have to show hands, but how many of you have seen patients post-op or just acute with swelling in their joint? You see therapists, OTs or PTs forcing the limb, okay? That's not very smart. It's not very smart. When I graduated, I did an internship from 97 for 2 months, so an 8-week internship, and then that clinic hired me. It was Health South, and now they're called Select. So in 98, and we had a great clinic. We were treating Miami Dolphin players, you know, we had a great clinic, but some of the therapists there would literally have a patient bite down on a towel after an ACL or a total knee replacement. And I mean acute. This isn't like, oh, you know, you got scar tissue and you're 8 weeks out, and then you gotta stretch it, okay? This is like acute swelling. And they would have them bite down on a towel and force their knee back, okay? Now, I like to keep it a little fun, so if you enjoy a pint every now and again, all right? I heard all the Tartan army of the Scottish showed up to Boston and drank Boston out of beer. That was hilarious. But if you take a pint glass and it's 16 ounces, if you fill it up with 16 ounces of fluid right to the top, can you stuff the water down and get an extra ounce in there? You can't. You know, an elephant sit on that thing. The water's not going to compress. Okay? Liquid fluid doesn't compress. So, if you have this liquid fluid in your knee joint, or your wrist joint, or your finger joint, or your shoulder joint, and you're forcing it, all you're doing is compressing the fluid, which then puts an equal and opposite pressure on the underlying joint capsule and also stretches, distends the joint capsule, and the patient has pain. And then if they have more pain, they have more muscle guarding. If they have more muscle guarding, they lose range of motion. So at Select, and you know, I haven't worked there in 20 years, so, but we would have like Worker Comp Friday where we had to like update notes for all our workers' comp patients, and you had to show progress. So guess what we did on Fridays? We stretched the shit out of our patients to get that extra 5 degrees, okay? Not smart, I'm guilty, I'll tell you, I did it, okay? So, and I like to tell you guys what I did, because I don't want you to think, oh, I graduated PT school and knew how to treat like Stanley Paris and all the grit. Like, no. I had to learn this stuff. I had great mentorship. So if you're sitting there thinking, oh shit, I knew that. Like, that's okay, that's what you're here for, okay? And if you're already not doing that, great, you're ahead of the curve. I can tell with a lot of companies, I can tell you there's a lot of therapists, more than half of the therapists out there still do this. They still stretch swelling, which is, you know, once you take off the sunglasses and look outside and see it's sunny out, you're like, oh, you know, I kind of want to do that. So one of the things I love about the course is, you know, illuminating some of these general principles that I suspect maybe were taught in PT school and OT school, but to kind of get glossed over. And then at the same time, I know it sometimes isn't taught because there's a lot of academics that don't treat clinically. So, I'll just say this, yeah. So, St. Augustine is 5 campuses now, and there's been, turnover as there is in any organization. So we actually had one orthopedic faculty member at a different campus, of course, who wanted a certain textbook because that had the treatment in it. And I was like, so you need a textbook to treat? Like, it was just bizarre to me. It was just bizarre, because if you know textbooks, like, they're fine for like techniques, but they're not really, and there's so much nuance to treatment, like, so anyway, it was just illuminating. And this particular person graduated from PT school, did a 1-year fellowship right out of PT school, and at the same time was doing their PhD, and within 3 years they were in academia full time. And if you're doing a PhD, I can tell you're not treating patients really, you're just full time doing that, plus your job. Anyway, so know the cause of the loss of range of motion is the overarching point. If it's muscle guarding, you're doing soft tissue in grade 2 oscillations. Are you doing that for a neurophysiological effect or a vascular effect? For a neuro effect. You're affecting the dorsal horn of the spinal cord through proprioceptive input, and that input is blocking the efferent motor area. Remember, 3 places. It also makes the patients feel good up here, right? Which is helpful. If you have muscle guarding, then you have to treat the vascular component of the muscle guarding, which means you have to do 30 reps or more of easy exercise that they can do. Okay. If you're treating, and that's the concentric motion. So if it's pec minor, you're doing protraction, not retraction. Okay. If it's the wrist extensors, you're doing wrist extension. If it's flexor carpi ulnaris because they have golfer's elbow, you're doing ulnar deviation. If it's spinal guarding, you're probably doing some kind of rotation because all the muscles do rotation. If it's joint effusion, the direction doesn't matter. So if it's muscle guarding, the direction matters. You have to do the concentric action of the muscle. If it's joint effusion, like if you just have effusion in the radiocarpal joint, do all directions. Do flexion extension, radial ulnar deviation, that's great. Okay? And that will lessen the joint effusion. If you got lower extremity, joint effusion post-op, this guy should be your best friend. I'll sometimes set a timer for 1 minute or 2 minutes and have them do it. And they'll walk up the thing. And I mean the first day post-op. And if it's an ACL, I have them do it with their brace on. The protocols, most of the protocols don't say do this for like 4 or 5 weeks with like a post-op ACL, but that's for strength training. You're not doing it for that. You're doing it for 50% for joint infusion. So you just set this up, and you usually have to put a little weight on it because the sled weighs something. So if you put it like on the first plate, sometimes when the patient's pushed, it doesn't come back. So you have to set it up a little bit. But without stretching your total knee patients, you'll get 20 to 30% more motion the first day without stretching them once. Okay? Upper extremity patients, the arm bike, if they have the range of motion to do it, All right. The arm bike's tough for the wrist. You got the neutral handles here, that's good. So they can stay neutral, so that's helpful. If they have muscle guarding, it's tough because just keep the hands open so they're not gripping. Just do that. Because remember the gripping, if they have, the gripping's a problem early on. All right. So muscle guarding, you're doing soft tissue, grade 2 oscillations, concentric exercise for that muscle that's guarded. For joint effusion, you're doing grade 2 oscillation, you're skipping the soft tissue, and you're doing 50% one arm exercise, and it doesn't matter which direction you go because it's in the joint. You do the grade 2 oscillations first because that lowers the viscosity, and then the fluid can come out of the joint capsule. Okay? Have you guys seen or worked with therapists that like do all the exercises first, and then at the end the patient gets the reward of manual therapy? I get it. I know I've literally treated 3 to 4 clinics at a time and managed 2 clinics, so I understand time constraints. But I just talk about ideally, the patient walks in, if they have pain and muscle guarding, you get them on the table for 5 to 15 minutes, and you adjust that first. Or if they have effusion, edema, you get them on the table and adjust that first. And then you do your exercises. All right. If there's a true joint capsule restriction, you have to stretch it with grade 4 mobilization or thrust manipulation, okay? In the presence of muscle guarding, the joint's gonna feel restricted, but it's restricted due to muscle guarding. So you take out the guarding first and then you reassess. All right, exercise. Talked about the lower end of Holton's curve, which is 50%. There's 3 reasons for that. We talked about the vascular 50%. So if you have muscle guarding, you're activating the concentric component of the muscle. If it's effusion, you're just activating anything around the joint. So if it's shoulder effusion, it's external, internal rotation, flexion, extension, adduction, you know, whatever you want. If it's the knee, it's obviously the knee's easy flexion, extension. The wrist, go all 4 directions. It's good to do all 4 directions. If it's lower extremity effusion, and to some degree upper extremity effusion, closed chain is better because all muscles are on. And if you have all muscles on for effusion, it pushes through the venous system better. I realize sometimes that a radiocarpal surgery, you can't do closed chain. So you just have to do open chain. But just remember, with closed chain, what's on? Everything. And when everything's on, you get more push through the venous system. That's why things like post-operatively, unless they're not weight bearing for PTs, like I'm doing calf raises, I'm doing leg press, day one. They walked in, unless they walk in hopping, they're doing calf raises and leg press. Now they can hold on to stuff. You know, if it's the right leg, you know, the left leg can be doing most of the work. You know, you can just be doing this thing, that's fine. Okay? The leg press, I mean, didn't they just get out of the car? People are like, you're putting me on the leg press? I'm like, did you walk here? Did you drive here? I say it just like this, did you walk or drive here? Oh, I drove here. Oh, so you did sit to stand. So you weigh about 150 pounds, we're gonna do 20 pounds. Divide it between both your legs. We're good. I say it just like that, and it comes off. Hopefully they laugh. If not, like it makes the point. Like, I got you. I've already did the, you know, the mental gymnastics here. Now sometimes I'm not a snark. Okay? It's difficult for me. But they are complete strangers you're meeting for the first time, so. Hopefully by the time we're doing the leg press, I've already, you know, established a rapport where I can be a little fun and snarky with them. Okay. All right. I will say, that aside, I really do that. I break it down for them just like that every time, and then they understand it. Okay? And, you know, I've been at clinics where, like, I've just watched for an hour and the leg press set empty, and it's bizarre to me, because sit to stand is one of the most important things that patients do during the day, other than walking, or feeding themselves, or cleaning themselves, you know, just, I'm talking more lower extremity stuff. In a clinic this size, I mean, you almost need like a little whiteboard over here to have a wait list for it, especially if you're doing a lot of post-op. We literally, at the last big clinic I worked at, I managed a clinic this size, we had 10 therapists, we had 10 PTs and 2 CHTs, OTs. And for the leg press, we literally had a whiteboard on it, and you'd have to sign up for it every hour. So, we'd be like, all right, I'm about to get off, who's next? Matt, you're up with your patient. You know, literally. So, we had like 5 surgeons that did total knees though. We had 20 surgeons working out of that office. And we saw a lot of foot and ankle and total knees and hips, so that was another, I don't know how the breakdown is here, if you get more shoulders or not. Ironically, the chief of our orthopedics was a shoulder surgeon, and he was the busiest guy, and he would only send 1/3 of his shoulder patients to us. It was bizarre. And his protocol for full rotator cuff tears was to not send them for therapy for like 10 weeks. And I met with the guy over and over, and he would nice guy me right to my face, saying, "Oh yeah, you're right, Thomas. I'll send him. They would never do it." So after a year, I just gave up. I was like,
This is last name, Steve.
this guy has no respect for me at all. You know, he let me write his protocols, and he put his name on them. That's a story for another time. All right, so 50% for vascular. We also have 50% for tissue healing. So if you have that acute patient, whether it's an ACL, meniscus, a radiocarpal joint, tennis elbow, we're doing high repetition, things 30 reps or more, to stimulate that tissue to repair itself. Okay? The major tissue we're going after are the fibroblasts, which are in the tissue that actually spin out when you do collagen. That's the tissue that actually does that. In cartilage, in bone, of course, it's the osteoblasts. In muscle, it's the myocytes. In cartilage, it's the chondrocytes. You don't have to know that on an exam, but you do need to know 50%. The second piece to 50% is for tissue healing. And if it's type 1 collagen, you need to introduce tension. If it's type 2 collagen, you need to introduce compression, decompression. All right. The third one at 50% is kind of an outlier. Oh, and the frequency for that is they're doing it like every hour or 6 times a day. So they have to do this a lot. If you have truly tight joint tissue or muscle tissue, you can stretch it up to twice a day, and that's 50%. So you can use active exercise. So let's say the pec minors are truly tight. You're treating the office worker, they got the rounded shoulders, you go in on pec minor and it's not painful, you do your pec minor test, which is basically just retraction, and it's just tight, no pain. Well, now you want to do opposite motion. You don't want to do protraction because it's not guarded. You want to stretch it. So you can do retractions, okay, is a great way to stretch that, okay? We're not doing door stretches anymore or corner stretches, whatever you want to call them, because the pec minor is not a glenohumeral muscle. You don't have to do abduction and external rotation. You can just do retraction. Even if the patient doesn't have shoulder pain, if you teach the patient a corner stretch, they're going to give themselves a anterior shoulder instability within a year. So I would strongly recommend you just don't use that one anymore unless you're treating burn patients. A patient population that a friend of mine actually sees and specializes in Jacksonville is post-operative breast cancer, women with breast cancer. So they do get a lot of scar tissue through here, and it does get tight. And it does limit abduction external rotation. That population is a population I can think of you would give a door stretch to. Outside of that, I really can't justify it. They get burned from radiation. And the scar tissue from the cosmetics, the reconstruction surgery gets tight. All right, so you do that once or twice a day. If you do 50%, like retraction, 3 sets of 30, 3 sets of 40, 3 sets of 50, if you do more than twice a day, it tends to overstretch it and it will get irritable. All right, the next level up is 60%, and that's getting tired around 25 reps. So somewhere between 20 and 30 reps, they should be getting tired. This is your spine, this is your rotator cuff. Okay, you shouldn't be doing 3 sets of 10 external, internal rotation anymore. Everything should be 3 sets of 25. And for those very tonic muscles like the spine and the rotator cuff of the shoulder, I don't recommend you training it at 75 or 80%. You just keep it there when they're targeted. So I never do 3 sets of 10 external, internal rotation. I always do 3 sets of 25. When it's time that the patient can really strengthen, I'll do lat pull downs at 3 sets of 10. I'll do bench press flies, biceps, triceps, all diagonal motions, D2 extension, etc. I'll do all that at 3 sets of 10 for strengthening. And is the rotator cuff on? Well, of course it is, but we're not when we isolate that. When you do deadlifts, is your spine on? Well, of course it is. But you don't need to sit here and do 3 sets of 10, a trunk rotation to train your core. It's all 3 sets of 25. And then when you're doing functional exercise, whether it's plyometrics or whatever it is you're doing high level, your spine's gonna come along for the ride at 3 sets of 10. Does that make sense to everybody? All right, good. Once your patient can do 60%, then they can do 75, which is 3 sets of around 15. And then once they get to strength building, it's 3 sets of 10. Your geriatric population is probably gonna be at 3 sets of 10 pretty quick, because the reason they're there is they're weak, for the most part. If you have your healthier, younger population, you're probably, when they get to the point where they're building strength, that's about the time they're probably ready for discharge. Okay, and remember your geriatric population, you know, they might be able to do sit to stand reps of 3, and that's what you're doing that day, you know? Or what I like to do is get them on the leg press and do 3 sets of 10, because I can manage the leg press to be a percentage of their weight. So if they weigh 200 pounds, you can do 100 or 150 pounds on leg press, 3 sets of 10. Because just them getting up out of a chair might be too much. Okay? For upper extremity stuff, patients may not be able to raise their arm, so don't forget about I just call it a low trap row, because the middle row is, okay, so I'm not gonna sit, but, oh, there's a stool there, but yeah, I'll just sit on a stool. So let's say this is the arm that's problematic. Okay, you ask them to raise their arm and they're doing this kind of thing. Okay, so with the non-involved side, you can actually bring this down and have them grab this here, and then have them do low trap rows. And then you can have them turn to the side and do scaption in a D2 pattern. This is D2 extension. All right, I do a lot of low trap rows in D2 extension. So remember, D1 is this pattern. Okay, it's important for eating. Most people can do it pretty easy. This they cannot do. This is D2 flexion, because it's what the humerus does. So this is, if you're starting here and coming here, it's D2 extension. So I hated treating shoulders. Hated treating shoulders when I first got out, because I was terrible at it. Absolutely terrible. If they had lost the range of motion, I'd get them supine on the table, I'd range them, I'd force it. Okay, I did all the things that I'm telling you not to do. Okay, so now I'm forcing a NIRS test. Okay, and they're getting pain, and then their subscaps coming on, and then they're losing more abduction, external rotation. I'm getting frustrated. Then I have them like trying to, you know, they can't raise their arm. So then I never put a dumbbell in their hand. I was never that bad. But I'd get them on the pulleys, and they'd be doing this, but they'd be doing it out here in abduction. Okay. So again, I wasn't as terrible as not leaving the thumb up, but I've seen, you know, therapists having the thumb neutral or even down and doing that like that. I don't know. So if you're gonna have them do the home pulleys for range of motion, keep their arms in tight, and have them do flexion only or scaption. Stop training abduction. I know I'm a broken record on this, but I just say it over and over again so you learn from my mistakes. Stop training abduction. Eyes. Eyes are good, Ys are good. Get rid of the T's. Okay? If you got a healthy shoulder, do the T's all you want. Okay? If they don't have good mechanics, take the T's out. Abduction, this is the hardest thing for patients to do. Right? You do internal external rotation here, then you do it here, then you do it here, and then finally, this is end stage. Okay? Get rid of the T's, you'll be happy. Other than, once they can do the low trap row really well, okay, let's think about this one more time, okay? They can't raise their arm, so when you grab the cable, you got cables in the back, you grab the band and they hold it, it actually unweights the arm, so it's easier for them to do it. The band's pulling them up, so you'll see their mechanics change like that. And if they're hiking their shoulder a little bit, bring the band down, it's too high, okay? And then as they progress, don't go to the red, don't go from red to, yellow's too light, you gotta start at like red. even green, because you gotta remember, it's not about the resistance band, it's about unweighting the arm. So the greens actually might be a little easier than the red, because it's pulling them up more, it's unweighting them more. Okay, once they can do pretty much as high as they can on the low trap road, then you switch them over to lap pull downs, and then you get the last 30 degrees. Okay, since I had someone explain that to me, one of my mentors explained that to me, it's changed my shoulder rehab, and now I enjoy it. The other thing is start close chain stuff. So if they have any scapular winging or just in general, do wall push-ups and progressive table push-ups and progress to, once they can do floor push-ups, they're pretty much ready to roll. But wall push-ups are great. I used to do like open chain punch-outs. I got away from that. I mean, it's fine entry, it's just a little too easy. I'm not saying it's a bad exercise to do, I'd rather do close chain wall push-ups. But it's not, it's not like a terrible exercise. I just think it's kind of like one of those that's, you're just kind of spinning your wheels. Okay, so that's the exercise really specific to, shoulder. And then once their range of motion is great, just like any joint, you just do all the stuff you do in the gym, 3 sets of 10 for strengthening. Okay? All right, so that's a pretty good review of the opening lecture as applied to upper extremity. Are there any questions with that? Everybody good on the concepts? Okay. Manual therapy and our other passive modalities are neuro techniques to ramp the nervous system down. That includes dry needling. And then you have to apply a vascular component to the body, and that's the exercise. All right. Okay. Can I just review like finger, thumb, radiocarpal, arthrokinematics real quick, and then we'll take a break in like 15 minutes? Does that work for everybody? Okay, great. Okay. So with our fingers, to my OT friends, please put the sniper rifles down. These are like little knee joints. I teach it this way for the PTs, okay? So these are little knee joints. Every PT knows that you have a distal femur that's convex, like a fist, and a concave tibia. So this is every finger other than the thumb. Okay? We're doing distraction, we're doing glides. When you're moving a concave on a convex, we'll glide go in the same direction. So if we want to improve flexion, we're doing a volar glide, extension and dorsal glide. Distraction is good for everything. Okay? What I want everybody to know is this extensor slip here, okay? The lumbricals insert into that, which is why the lumbricals do flexion of the MCP joint and extension of the PIP joint, okay? And by extension, the PIP joint. So we have that Buntle-Littler test, that special test we'll review later today again. But that's specific to either finding a joint restriction versus a lumbrical. And I'll let you guys speak to this, but a lot of people get lumbrical tightness, don't they? Yeah. So you want to use that test to treat, which is going to be the opposite motion. So if lumbricals do MCP flexion and PIP extension, you want to do the opposite, which is this. Okay. All right. Now we have the radiocarpal joints, okay? And we all, I had you guys do little tic-tac-toe boards on your hands, right? Okay? So think of it as 6 areas. So you have 1/3 is the radius, 1/3 is the middle, 1/3 is the ulna. And you got 2 bones in each row, okay? Or pillar, or column, however you want to think of it. All right? And on the radial side, you have the scaphoid, and then you have the trapezi group, and the trapezi group articulates with the first metacarpal, that's the CMC joint, that's the one that's weird, it's like that cellar joint. It's concave in one direction, convex in another direction. We're gonna get to that in a minute. Then you got lunate and capitate, and triquetrum and hamate. So the whole proximal row is convex on a concave. So roll and glide go in opposite directions. So if you want to test or treat extension, you have to do a volar glide. Okay? Remember, this is the reference position for the body. Okay, I didn't pick it. All right, this is just what they did. So if I do extension and it's opposite motion, volar glides for extension at the proximal row. Flexion, dorsal glide. Okay, if I'm doing radial deviation, it's going to be an ulnar glide, and if I'm doing testing or treating ulnar deviation, it's going to be a radial glide. Okay. Now the distal row is different. You have your trapezius group is concave on the scaphoid, so to test or treat flexion at that joint, and about 30 degrees of your wrist flexion occurs there, you need to glide volarly and dorsally for extension. If it's the capitate on the lunate, it follows the proximal row, it's convex on concave, so volar glide for extension, dorsal glide for flexion. If it's the hamate, it's irregular, so it doesn't matter which way you push it, it'll help. But I don't know, I've rarely had hamate issues. Do you guys get hamate on triquetrum ever? I've never really seen it, but you know, anything's possible. All right, now the thumb. So you have a sellar joint or saddle joint. So if you think about a horse's back with a saddle on it, the medial lateral part of the horse is convex. Okay, your legs go over that part. And then, but front and back is concave. That's what I call a saddle joint. Okay. So for flexion and extension, which is towards the flexions towards the ulna and extensions towards the radius, this will be a test question. Okay? For flexion and extension, roll and glide go in the same direction. So I'm pushing ulnarly for flexion and radially for extension. Pushing same direction, so flexion is ulnarly, okay? And I'll move it, this is for the metacarpal, first metacarpal on the trapezius group, okay? Trapezius group, remember, it's trapezium and trapezoid. We just call them trapezius for short. Okay? Pushing ulnarly for flexion, radially for extension. Then for ABA deduction, which is your sock puppet, okay? Abduction is opposite. It's a convex moving on a concave. So abduction, I'm going to push dorsally, and adduction, I'm going to push palmarly. Palmarly, volarly, and anteriorly are all synonyms. So you need to know all three. Palmarly, volarly, and anteriorly. Okay? Those will all be test questions. All right. And that's the wrists and fingers, guys. That's the arthrokinematics for it. Okay? I did that in 5 minutes. I always double the time because I'm a talker. All right, it's 1:45. Let's take a little coffee break, come back right before 10, and we'll get to the elbow.